Stream entitled Sudden Cardiac Arrest Risk Reduction Strategies, Clinical Case Conversations. I'm Dr. Byron Lee from Stanford University Medical Center, and I'm honored to be joined by Dr. Sateesh Kesari from TriHealth Heart and Vascular Institute. We have a couple cases that we are going to present today that illustrate some important points about sudden cardiac arrest risk reduction strategies. My first case is Mr. BB. He's a 48-year-old male who presented with coughing and shortness of breath. We found that his troponins were positive, and eventually he was diagnosed with an NSTEMI. Cardiac catheterization surprisingly showed 3-vessel disease. His echo showed ejection fraction down to 35%. He underwent successful CABG. Like many patients post-CABG, he had a fair amount of ectopy. First, it was AFib, and then he started to show non-sustained VT. Made us nervous, but eventually the non-sustained VT got better. He was discharged feeling well. He was in sinus rhythm, ambulating, chest pain free, and shortness of breath free. 1 month after MI, he was seen in our EP clinic. He was in sinus rhythm, but because he had some atrial fibrillation during his hospitalization, we gave him an ambulatory ECG monitor to see how much AFib he had. 3 months after MI, red alerts were sent to us from the ambulatory ECG monitoring company. And this was back in the day when we were still getting faxes. And this is the first fax to our office. And you can see a very unstable rhythm. When the nurses brought this to me, I said, oh my God, get him on the phone, call his family, see if he's okay. We couldn't get him on the phone. And then another fax came in. And then we saw this and we said, oh, I think he might be okay, but still keep trying to get him on the phone. Eventually, we got a family member on the phone. And what we found out had happened was this lucky guy was in cardiac rehab when all that happened. He had collapsed, but because there was staff there and a crash cart there, they were able to defibrillate ventricular fibrillation immediately. He actually had ventricular fibrillation 2 additional times requiring cardioversion. He is the exact kind of patient that we studied in our VEST trial. This is the main results from our VEST trial, which was published in 2018 in New England Journal of Medicine. We took similar patients who were post-MI, low ejection fraction, all EF less than 35%. And our main result, overall mortality, death from any cause, you can see on the left panel here, a 36% risk reduction of all-cause mortality in the group that wore the wearable cardioverter-defibrillator vest. And this was statistically significant with a p-value of 0.04. Now, admittedly, people are often confused about the VEST trial because the abstract and the conclusions of the abstract were a little bit disjointed. And the reason for that was because our original primary outcome was the right upper panel, which was sudden and ventricular tachycardia deaths or sudden deaths. And you can see there was a trend toward improvement in sudden deaths, but this was not statistically significant. So our abstract was a little confusing. In the body of the abstract had the overall mortality benefit, but the conclusion had the sudden death outcome because that was our original primary outcome. As expected, though, all the participants in the VEST trial who got the vest, who had an appropriate shock for VT or VF, every one of them were successfully converted to sinus rhythm by the wearable cardioverter-defibrillator. 15 of those patients survived to 90 days, which was the end of our trial. 6 ultimately did die, all of which were in the wearable cardioverter-defibrillator group. So based on the results of our trial, which was published in 2018, some organizations, particularly the Japanese Heart Association, have moved from class 2B to class 2A, this indication, this patient population, in terms of whether they ought to get the wearable defibrillator. For patients post-MI within 40 days or less than 90 days after revascularization, if their ejection fraction is low, 40% or below. The current guidelines from 2017 say class 2B to use the wearable cardioverter-defibrillator. As I mentioned, it has been moved up by some societies to class 2A if overall mortality was our primary outcome of our study. I think it would be class 1, but because it wasn't, it is still going to probably continue to be a class 2B or class 2A indication. So with that, I'm going to turn it over to, Dr. Kesari, unless you have a question for me.
Byron, yeah, nice talking to you again. And it's a great review of the VEST trial, which you were very closely involved with. I had a question. We have in this ischemic cardiomyopathy population, what do you do with your post-bypass open heart surgery patients with reduced ejection fraction at the time of discharge?
Yeah, so the studies have shown that people post-CABG similarly can have a high risk of sudden death in the first few months, just like the post-MI patients. And so I think those are also reasonable patients to consider for a wearable cardioverter-defibrillator. It's a temporary high. Yeah, did you lose me for a sec? Hopefully I didn't get lost. So I think those are also reasonable patients to use a wearable cardioverter-defibrillator. Okay, it looks like Dr. Kesari got dropped. Hopefully he'll sign back in. I can start going through his slides as we wait for him to come back. I think the wearable cardioverter-defibrillator is a great option for anybody with temporary increased risk of sudden death. So patients post-MI, like the ones we studied in the VEST trial, patients post-CABG that Dr. Kesari had alluded to, patients getting their ICD removed, for example, those are all reasonable patients to consider for the wearable cardioverter-defibrillator vest. So I just yacked away to fill up time until you came back. But now that you're back, we can go through your case.
Hey, thanks. I wasn't sure if I lost you or I was lost. I was talking for a bit there too. Thanks,
Yeah.
Byron. I appreciate that. So I have a patient with a non-ischemic cardiomyopathy that I'd like to present and talk a little bit about data in the setting of a non-ischemic cardiomyopathy. Here we have a 44-year-old Caucasian female that presented from an outside hospital with acute heart failure. Her ejection fraction was severely reduced to 20%, severely dilated left ventricle. Cardiac cancellation during a hospitalization demonstrated normal coronaries, very labile blood pressure, and could only tolerate valsartan 20 and dapagliflozin 10, and was discharged on a wearable cardiac defibrillator actually March of this year. No significant real past medical history, and the initial workup demonstrated just mild hyponatremia, an EKG that demonstrated normal sinus rhythm with a pretty wide left bundle branch block. Telemetry was actually unremarkable, no atrioventricular ectopy. The echocardiogram, as I mentioned before, severely reduced ejection fraction, a very dilated LV of 7.3 centimeters, and RV systolic estimated pressure greater than 55 millimeters of mercury, and an IVC that was dilated. Cardiac MRI confirmed an ejection fraction of about 10%, markedly dilated LV. No late gadolinium enhancement to suggest scar or fibrosis. And the left heart catheterization additionally demonstrated an LVEDP of 18. The right heart catheterization demonstrated normal right-sided filling pressures and mild to moderate post-capillary pulmonary hypertension with a wedge of 21 and a preserved cardiac output and index. And the patient made it to the 1 week office follow-up, had metoprolol, spironolactone added in addition to the valsartan, and her SGLT2 inhibitor had to be held due to vaginal infection. And these are her non-cardiac medications. Interesting enough, 3 weeks after hospital discharge, she reported heart racing, tightness in her chest, and found to have this wide complex sustained ventricular tachycardia lasting a scary 52 seconds. The average heart rate around this arrhythmia was 79 beats per minute, and she was averaging a systolic blood pressure in the 90s. And naturally, we called our EP colleagues who saw her right away, got a biventricular ICD implanted. And surprisingly, this all happened in a short period of time within 5 weeks of hospital discharge, highlighting the points that we're trying to bring to light today. I think what's important to know that GDMT has a effect. If we look at a meta-analysis of 12 randomized clinical trials, 40,000 patients conducted in the heart failure sphere from 1995 to 2014, the cumulative sudden cardiac death rate from these randomizations was 2.5% in the initial trials, and then decreased about 1% in the more recent trials. That's in the contemporary management of all our 4-pillar GDMT therapy. So showing a benefit of GDMT, but also highlighting a residual risk that remains that we need to address. These 2 trials demonstrated that addressing this residual risk with an ICD right off the bat is probably not beneficial. And that's the Dynamit and the IRIS trial. They're open label, Dynamit being an open label randomized controlled trial in patients with a recent myocardial infarction with or without ICD. The median follow-up was 30 months. There was no significant difference in overall mortality between the treatment groups. But when you break it down into those related to sudden cardiac death and arrhythmic etiology, there was a significant difference with an early differentiation in the curves within actually 6 months. So even within 3 months, there's a statistically significant difference in their outcomes. And you can see the curves diverge within about 3 months or so, or even earlier. The IRIS trial was a similar ischemic cardiomyopathy population, no difference in overall mortality, and an improvement in the rhythmic subset that we looked at with a significant p-value there too. And lastly, I want to bring up a more recent contemporary evaluation. In Germany, in every patient that got a wearable cardiac defibrillator, which accumulated about 19,000 patients throughout the whole country, they followed these patients, and 11,000 of those patients, the majority, had non-ischemic cardiomyopathy. And what they identified that in this population of patients, there's a 6.53% or incidence of sudden cardiac death in the non-ischemic population if you take an incidence per 100 patient years. So therefore, if you have 100 patients followed for 1 year, 6.53 was the incidence of non-ischemic cardiomyopathy related sudden cardiac death. And you can see the ischemic cardiomyopathy was 9.1. Both of this is higher than we've seen even in the more contemporary trials like Paradigm HF and their sudden risk scores, highlighting maybe the higher risk than we previously knew. I think, but what's more interesting is if you look at the graph below, is the time of these events. And as you can see, within the first month, is a large proportion of these sudden cardiac death events, both in the ischemic and the non-ischemic population. And it teeters off over the long run, but it's still there to a certain extent, even 6 months out. We want to talk a little bit about how we approach patients in our heart failure clinic. We have a virtual heart failure clinic that incorporates all these devices as described above. We use the wearable cardiac defibrillators in ischemic and a non-ischemic population. We have a specific device nurse that monitors and acts on these alerts. It's a multidisciplinary approach. We use PAs, NPs, pharmacists, heart failure navigators, and social workers to really bring a comprehensive program. It's also tied into our transition program. So even before they come in within 1 week, there's a call from a pharmacist, a navigator, a dietitian, and a nurse practitioner. We tie it to smart phrases that pick up the data for heart failure decompensations and tie it to diuretic protocols with an escalation strategy. The benefits that we've seen: patient adherence, reducing anxiety, preventing loss of follow-up, so therefore tagging patients with all these devices. Patient engagement goes up. We share readings either in the office visit or through MyChart messaging. And we use it within the heart recovery program, looking at rapid GDMT titration, especially the average heart rate. Really helpful when the heart rate doesn't make sense in the office. It might look low, but the average heart rate's 70, 80s on the wearable cardiac defibrillator. So in summary, we see how we approach patients with an ischemic and a non-ischemic cardiomyopathy and address that sudden cardiac risk elevation in that short period of time prior to the point that they need or meet the ICD indication. Do you have any questions regarding that?
Yeah, well, I want to point out that I think it's great that you have a dedicated device nurse handling wearable cardioverter defibrillator data, because you do need to get the hang of it, and it's great to designate specific people to manage that. I will like to ask your opinion on this as a heart failure specialist. You think that non-ischemic cardiomyopathy patients have high enough risk to warrant a wearable cardioverter defibrillator, an ICD or an ICD? A lot of people say their risk is lower than the ischemics, and so maybe they don't need it. What do you think?
I think it is probably lower than the ischemics, but as that recent study from Germany shows, it's elevated more than we know. And as per my example, just from a case from 3 months ago, we saw that risk. I think we don't know exactly how to risk stratify these patients. We use a crude method of an ejection fraction, maybe LV dilatation. There's other trials that have picked up other risk factors, and we sometimes look for fibrosis or NSVT on the monitor. But in the future, we're looking at machine learning and computational models and AI to better predict patients. And I think what we have to do move forward now is look at risk factors, add on GDMT, and then figure out how we can risk stratify a little bit better to catch the ones that will benefit more.
Yeah, that's great. I totally agree. Well, with that look to the future, I think it's a good time to close. I want to thank everyone who joined us today, and I hope the presentations were helpful. Thank you very much. Bye now.
Thank you, everybody.